The drugs that are actually used for the partial seizures are more or less the same for all different types of seizure of the partial seizures. However, for the generalized seizures, we cannot generalize the drugs for each type of the seizures because most likely they are treated individually with different anti-epileptic drugs. Like the importance of the anti-epileptic drugs. So you know that how seizures disturb people life. They can focus on their work. They cannot focus. That's my. I mean, that might affect their daily life, their daily routines. So we have to be careful and we have to treat those people because that's dangerous. Also, it might cause like car accident or people who goes under seizures might have unexpected accidents. So it alters their life and it interferes with the brain function, also memory and endocrine. At present, about 70% of patients can have seizures well controlled, and many will experience some side effects. Surgery may help some individuals with focal seizures, but of course, not all type of seizures. So the goal for our when we treat patient is that we want to prevent seizures, but unfortunately there is no medications that can be used as a prophylaxis if we know that this patient might have seizures, as well as or let's say prophylaxis for people who we are expected to have epilepsy, like if there's a family history or such a thing. So the medications that are available now just prevent the seizures. It's not prophylaxis, and it goes with it and it's uh, parallel with the treatment. Also, there are these medication might have some side effects. So we're trying to reduce or prevent the side effects of these medications, the drug-drug interaction, worsening the current medical problems if that patient has other medical problems. We want to improve the quality of life for those people, and we want to provide the simple, cost-effective care, since we know that this is a chronic disease and the patients will be on the treatment for the whole life. So the ideal characteristic for the drugs that we use it for seizures is that it has to be effective against the specific type of seizure that the patient has. Sometimes we use broad spectrum drugs, but sometimes we have to be very specific. We have to think about the toxicity, so we try to choose a medication that has less or no acute CNS toxicities, little or no systematic toxicity, specifically if that patient has liver or kidney problems. Active orally, so you know that this is a chronic disease, so the patient will be on the medications every day or every week. So we have to think about an oral options. Long half life, so it's easier for the patient to have to take the medication once per day rather than 3 or 4 times a day. There's no drug interaction, specifically with elderly people. Does not affect the brain developments and developments in general. Oh, the list of the anti-seizures that we have been available since the discovery of the anti-epileptics. There are some old generation of anti-epileptics that are still used until now. Barbiturates, hydantoins, the oxalolidine diones, the succinimides, and then the acetylurias. Those are structurally related. And then we have the drugs that are also under the older generation, but they are structurally not related to each other, such as carbamazepine, valproic acid, and then benzodiazepines. The newer medications since the 1990s are different in their structure and are different also in their mechanism of action. And that's included filbamate, gabapentin, lacosamide, lamotrigine, and also other medications that we will go through some of them throughout this lecture. This is again the anti-seizure drugs, but that they are categorized based on their usage. So if you can see that in tonic-clonic and partial seizures, carbamazepine, lamotrigine, phenytoin, and valproic acid can be used. In case of absence seizures, we can use clonazepam, ethoxyzumide, valproic acid. Although ethoxyzumide is the most commonly one that used for absence seizures. For myoclonic seizures, clonazepam, lamotrigine, or valproic acid, and the rest of the medications can be used as a backup and adjunctive medications. Right. Before we go into the mechanism of action of these medications, let's do some overview about what we talked about yesterday in the neurotransmitter lectures, and then we can link it to the mechanism of action of the anti-epileptic medications. So please, if you can go to the menti.com and then add the code, and then we start the questions for the overview. So how many of you are ready? I hope to see more than 23. So the 23 that I saw yesterday, I hope to see more than that number today. Okay, so let's go to the first question or the first statement. So glutamate is an inhibitory neurotransmitter, while GABA is an excitatory neurotransmitter. Is that true or false? Do yourself a favor and do not look at yesterday's lecture. So just answer from whatever you remember since yesterday, and that will be a good evaluation for yourself. So do you think that glutamate is an inhibitory while GABA is an excitatory? Is that true or false? We talked about that yesterday. Type. So it's actually false. So can someone tell me what's the true? It's the opposite. Yes, glutamate is an excitatory, while GABA is an inhibitory neurotransmitter. And these are the very important two neurotransmitters, as you know, in epilepsy. Okay, so the next question. In response to depolarization to a threshold level, the first step is that an action potential is initiated, inducing opening of calcium channels. Is that true or false? So in case of depolarization, uh, and the action potential started, does it that action potential started with the opening of the calcium channels? Is that true or false? Okay, so let's see. It is false. So what is the change that you can make to this statement to make it right? Yes, it's sodium. So the action potential usually initiated by opening the sodium channels. Okay, so moving to the next. When the action potential arrives at the presynaptic terminal, it initiates the release of the excitatory or inhibitory transmitter. Is that true or false? I guess we mentioned that yesterday many times. Okay, so I guess I just have the 20 with me. Oh, good. We have 21. 22. Yes. Right. So that's true. If the action potential arrives to the end of the presynaptic terminal, then that's stimulated the transmitter release. Right. The next statement says depolarization at the nerve ending and entry of sodium initiates docking and then fusion of the synaptic vesicles with the membrane of the nerve ending. Is this true or false? So this statement is false. Can someone tell me how we can correct this statement? Yes, calcium is the ion that is important for the fusion and then releasing of the fusion of the synaptic vesicles to the membrane of the presynaptic neuron, and that stimulates the release of the neurotransmitter. Yes, sodium initiate the depolarization, and then the calcium comes in, and then the calcium after it comes in, it stimulate the synaptic vesicles fusion to the neuron membrane, and causes the release of the neurotransmitter. Type. The next statement says interaction of the excitatory neurotransmitter with the postsynaptic receptor produces a localized depolarization. The excitatory postsynaptic potential, which is the excitatory postsynaptic potential, through an increase in permeability to sodium. To sodium. Is this true or false? More than 15? Yes, 16. I want to see the 20 at least. Yes, 17. Please give me the 20. Okay, thank you. So this is true. So thank you so much. We'll move to the next statement. The inhibitory transmitter causes a selective increase in permeability to potassium or chloride. That results in a localized hyperpolarization, which is the inhibitory postsynaptic potential. Is that true or false? Mhm. Thus, the inhibitory transmitter causes increase in permeability to potassium or chloride, and that causes hyperpolarization and inhibitory of the postsynaptic potential. One more. 20, please. 20 response, please. Yes, thank you. So, this statement actually is true. So, for the people who said it's false, what do you think is the true? What do you think that makes this statement false? Why it's hyperpolarization is not true? Right. Go back to yesterday's lecture again. Like the next question is that you need to focus here a little bit. The excitatory postsynaptic potential initiates a conducted action potential in the postsynaptic neuron. طيب? And then we initiated the excitation of the postsynaptic neuron. This can be prevented by the high polarization induced by a concurrent inhibitory postsynaptic potential. يعني هنا we have two neurons that are يعني initiating the conduction in the postsynaptic in the post neurons. So we have one neuron that initiates the action potential in the postsynaptic neuron, and at the other side also we have another neurons that causes hyperpolarization and inhibitory postsynaptic potential. So can this prevent the excitation that happens by the excitatory neurons? Increase the threshold of which one, ya Hala? Of neuron receiving these signals. Okay. I'm so sorry. This statement actually is true. Yes, it's true. Yes. The thing is that you have two neurons that, يعني انتوا عارفين in the brain there's not only one neuron that's connecting to the other neuron. So if we have an excitatory neurons that excited the postsynaptic neurons, and then we have another neurons that releases an inhibitory neurotransmitter that can be actually reduces the excitation of the post neuron. But that is depends on the يعني that depends on the level of the excitation that's happening, our level of inhibition. We will see that in today's lecture, but I want you to get that idea that an inhibitory neuron also can be or inhibitory neurotransmitter that can excite the postsynaptic neuron can be augmented by an inhibitory neurotransmitter. Okay. Right. The transmitter is dissipated by enzymatic destruction only. Is that true or false? Okay, two more, please. Thank you. It is actually false. How can you make? You can make it very tiny little change that can make this statement true. What is it? Yes, remove only, and that's so. What other ways that we can get away of the transmitter with? Yes, we can do the reuptake can happen. Also, the neurotransmitter can be taken up by the glia cells. Also, it can be also degraded in the synaptic cleft. Like the last one before we go into our lecture again, depolarization of the postsynaptic membrane can permit calcium entry if voltage gated calcium channels are present. Is that true or false? One more? One more, please. Out of the 102. Okay, thank you. So this is a very clear statement. This is true. If you have a postsynaptic uh, calcium channel and then the depolarization happening in the postsynaptic, I mean, that can allow the calcium entry if there's a calcium channel of the membrane. Okay, so now we're going to talk about the excitatory synapse and the inhibitory neuron. So what happens is actually so f- we're gonna start here from number one. So what happens is that normally charges normally there is an equal charge in the inside the neurons and outside, so on both sides of the membrane. So what happens is that when sodium channels open, then sodiums move in, right, into the neuron, and that causes membrane depolarization. And membrane depolarization also activates the high voltage calcium channel on the presynaptic neuron again also, and that's activate or rushes the calcium to move inward into the neurons, and that also led to triggering moving the synaptic the vesicles into the membrane into the membrane, and then stimulated the releasing of the neurotransmitter. An example here is that we have the glutamate, which is an excitatory neurotransmitter. So it is released now. What happens if it's released? So glutamate, the receptors of the glutamate are the NAMDA and AMPA receptors, right? So what happens is that glutamate will bind to the AMPA receptor, and that will open this sodium channel and allow sodium to move in, right? At the same time, also, glutamate will bind to the NAMDA receptor, open the calcium channel, and then allows calcium to move into the postsynaptic neuron. In addition, also, on the postsynaptic neuron, calcium will enter from the through the T-type or the low voltage gated channels, calcium channel, and that opens also and responds to the depolarization at low or at the resting potential. So when there is so we know that the glutamate is an excitatory neurotransmitter. When there is too much excitation by the glutamate, what happens is that GABA neurons or GABAergic neurons it comes and play the role here to reduce the excitation. So what happens is that GABA ergic neuron releases GABA, a neurotransmitter, which will bind to the GABA A receptor on the postsynaptic neuron, and that open the receptor and allows the chloride, to enter the cells. At the same time, also, um, so this step will correct the positive charges that's going on the on this neuron. So we have the sodium and calcium here, and then chloride comes in, and that balances the charges around this on the sides of this membrane. So that normalizes the charges on both sides, and that's limiting the neuron's ability to respond also to further stimulation from the glutamate. So, and then GABA, if we have enough GABA here, then GABA neurotransmitter here would dissociate, and then it will be reuptaken into the GABA neuron by the GAT1 transporter, and also it will be removed by at the end will be removed and degraded by the GABA transaminases enzyme. Okay, is that clear? Is there any question in these steps? At the post in you mean here, Dima? In this step? Yes. If we have too much of the glutamate released, because we call this is a low voltage gated calcium channel. So if the potential is at or below the resting potential, then the calcium comes in also on this neuron. Okay. Right. I hope that's clear. Okay, so this will lead us to the molecular targets of the anti-seizure drugs at both the excitatory glutaminergic synapses, and we'll add in the next slide, we will see the inhibitory synapses. So the different targets we have here. First, we talked about the stimulation or the activation of the potential by activating the sodium channels. So we can target the sodium channels on the presynaptic neuron. We can also target the calcium channels on the presynaptic neurons. There is also some theories about targeting the potassium channels on the presynaptic neurons. Also, some other targets are targeting the synaptic vesicles, which is the SV2A, which is a protein that's important for the vesicles to fused with a membrane. And then we have another target, which is the CRMP2 protein. And that's the protein that's involved in the neuronal differentiation and axon growth. So enhancing or targeting, let's say, this protein, enhancing a slow inactivation of the sodium of the voltage gated sodium channels. And then on the postsynaptic neuron, we can target AMPA receptors, can be blocked by different medications, as well as NAMDA receptor. And we'll see most of that in the following slides. The next targets are the targeting inhibitory GABAergic synapse. طيب انتوا عارفين انه في seizures we have so much excitation, right? So in the previous slide we saw that we can inhibit the excitation, but in this slide we want to do the opposite. This is an inhibitory neurotransmitter, so we want to stimulate this neurotransmitter in order to give us an inhibitory effect. So what we can do here, we can use, for example, GABA transporters, like targeting GABA transporters, specifically the GAT1. So if we target GAT1 on the GABAergic neuron, then we can block the reuptake of the GABA. We can also target the GABA T or the GABA transaminases, so we're blocking the degradation of the GABA. Also, GABA A receptors to prevent to stimulate the effect of GABA. Also, potentially some GABA B receptors also, and then synaptic vesicles proteins, so we can stimulate the release of GABA neurotransmitter. Okay. Now we're going to talk about the drugs. So some general properties of the anti-seizures drugs, the pharmacokinetics of the anti-seizures drugs, is that they most likely have similar pharmacokinetics with some differences in between. So we have to think that because they are taken by orally, and they all need to be entered into the CNS, so they share some properties. In terms of absorption, so they are well absorbed, since we know that they most all of them mostly are given orally. We have some of these medications are given orally, and at the same time we have an IV or IM route of administration. But however, we have an oral route of administration also for all of them. The plasma protein binding, mostly these medications are not highly bound to the plasma proteins. For the metabolism, they are metabolized by the liver. And there is a very important thing that a couple of these medications are affecting the liver metabolizing enzymes. So we have to be careful about the combinations, as well as about people with the genetic diseases, or not genetic diseases, I mean genetic mutations for the gene of these metabolizing enzymes. And then at the end, we have the elimination, and they are cleared most likely. The plasma clearance is relatively slow. They stay a long time in the blood. That's why we said that we are most likely given these medications once a day in order to increase the compliance, as well as remove any reducing the seizures. Right. Before we talk about the phenytoin, which is the first medications, I would like to make a quick explanation for the sodium channel. So phenytoin actually binds to the sodium channel, but I want to give you a difference in the sodium channel between a closed sodium channel and an inactivated sodium channel. Because in this stage where most of these anti-seizure drugs work, so what happens is that, at the resting state, at the minus 70 millivolt potential, we have the sodium channel closed, okay, at the resting potential. What happens when the potential raised to about minus 50s? That leads to opening of the sodium channel, right? So that allows sodium to move into the cells, increasing the potential more towards the positive side to the 30. That makes the sodium channel to be inactive but not closed. طيب, it becomes inactivated for a brief period, and that's but it's still not closed. طيب. And then after that, what happens is that the potassium channel is opened, and that makes the potassium leaves the cells, and that leads to, of course, hyperpolarization and the resting state. So what happens in the epilepsy is that the action potential firing is happening faster without the enough time of the resting state. So this is the normal action potential, and this is what happens during seizures. So the action potential is happening very quick in a shorter resting state or USS resting state time. And this is the stage that where most of the anti-seizures medications are working. And we'll see now in the phenytoin. So phenytoin is one of the oldest medications that is used for generalized tonic-clonic seizures, as well as for partial seizures. So the phenytoin actually blocks the sustained high frequency repetitive firing of action potential. How? It blocks the sodium channels and inhibiting the generation of rapid repetitive action potentials. This leads to prolonging the inactivation state of the sodium channels. Phenytoin actually give us this effect or helps to reduce the seizures, since it has couple actions. So it reduces or it blocks the sodium channel as a time dependent block. So as much as we have the drug in the blood, as much as blocking we have. So that's because the dissociation is very slowly and the half life of the medication is long. And also, they are use dependent blocking. So as much as we are using the phenytoin, so the fraction of the inactive channels is increased by the membrane depolarization and repetitive firing. The third dependencies is the voltage. So the voltage is the phenytoin binding is faster when the channel is open or inactive, other than when the channel is closed. So the action of the phenytoin depends, as I said, on three things. If we have, for example, a drug that has use dependent and voltage dependent, but it dissociates very quickly and it disappears from the blood, then we do not get an action that's similar to phenytoin. Another also theory of the mechanism of action of phenytoin is that also phenytoin reduces calcium permeability, and that explains why phenytoin inhibits also calcium, and that reduces the secretory process of the neurons as well as for the hormones. So the neurotransmitters as well as for the hormones. At the end, so this is mostly the phenytoin decreases the synaptic release of the glutamate and enhances the release of GABA, and that's mostly due to the action, other than its action on the sodium channels. But that's what people have seen that. I mean, like, what does phenytoin does on the glutamate and GABA neurotransmitters? Right, the kinetics, قلنا it is highly dependent on the dose. So if we increases the dose of the phenytoin, then that means that we're increasing the concentration as well as increasing the elimination يسموها إيش in the first order, or it's in يعني in a stable state. Increasing the dose, that means increasing the elimination until we get to the point where the hydroxylation enzyme with the hydroxylation system gets saturated. Then what happens is that we're increasing the dose, but we do not see the same proportion of increasing the elimination. And we're increasing the dose, but elimination it's still not increasing at the same level. Why? Why this is important? This is important because phenytoin is metabolized into an inactive metabolite. So if we're having so much of phenytoin, but that's not metabolized in the body, that means that we're getting into the toxicity level, because we need this conversion of the active phenytoin into an inactive form in order to reduce the toxicity of phenytoin. However, if the metabolizing enzyme or the metabolizing system is get saturated, then we might reach to a toxicity level of phenytoin. Again, we said that the elimination is dose dependent, so it's very important. I mean, it depends highly on the enzymatic metabolism. We have two forms of the phenytoin: the phenytoin sodium, which should not be given as an IM; it's most likely given as an oral. And then we have also the phosphenytoin, which is given parenterally, IM or IV. Yes, one important thing also is that the metabolism of the phenytoin is enhanced by the metabolizer, by the liver metabolizer, enhancing liver metabolizing enzymes like other drugs, and as well as it also affected by the drugs that are inhibiting the metabolizing enzymes as well as inducing the metabolizing enzymes. So if the drugs inhibiting the metabolizing enzyme, that means that we will have a less concentration of phenytoin. If we have a drug that is inhibiting the metabolizing enzymes, that means that we have sorry, if we have a drug that inhibited phenytoin metabolizing enzymes, that means that we have what? if the drug is uh, لخبطة أنا معلش. Yes, more. Thank you, Nov. So the presence of the inducers inhibited the phenytoin, while the presence of the inhibitor producing or enhancing the phenytoin. Thank you. Toxicity, phenytoin, the features or the toxicity that caused by phenytoin are nystagmus, diplopia, ataxia, which is more dose related. So if it reduces the dose, that means that we will not see these toxicities. Sedation and slurred speech, gingival hyperplasia and hirsutism. Long-term use also might causes coarse facial features, peripheral neuropathy, abnormalities in the vitamin D metabolism, which will lead to osteomalacia. If phenytoin is used during pregnancy, then there's a high chance to see babies with a cleft lip and palate. So we have to be careful. Some other reactions that are rare to the phenytoin, which is the idiosyncratic reactions. We will see that with other medication that there are some side effects that's not related to the effect of the medication itself. Also, we have to be careful about discontinuation. We have to do gradual discontinuation. Other than that, we might see status epilepticus. Right. The next medication is the carbamazepine, which is marketed first as a treatment for the trigeminal neuralgia. It is again used for partial and generalized clonic seizures. It's mainly giving the anti-seizure effect as it inhibits or it blocks the sodium channels, as well as there is some theories that says that it's potentiate also the voltage-gated potassium currents, which is the hyperpolarization. So it's slowly absorbed after the oral administration. It induces its own drug metabolism. So again, it is itself as an inducer of the liver enzymes. So we have to be careful about carbamazepine. Specifically, also that carbamazepine is one of the very common medication that is prescribed for seizure in case of pediatrics. So that causes interaction with other medications if they are used. It's not well tolerated in all people. Toxicity, the most common are diplopia and ataxia. Also, some GI effects at higher doses and occasional hyponatremia. Some other reactions, such as erythematosus, skin rash, and also blood dyscrasias, which is fatal cases of aplastic anemia and agranulocytosis. The next medication is the lamotrigine, which is also suppress the firing by blocking the sodium channel at the inactivated state. But if you can see from this illustration that carbamazepine, phenytoin, topiramate are most likely binding to the sites like close similar site. However, the lacosamide, lamotrigine, valproate, and zonisamide, they also block the sodium channel, but that's at different sites of action. It might also inhibit the voltage-gated calcium channel, specifically at the N, P, and Q type of the calcium channels. It decreases also synaptic, and at the end, it decreases the release of glutamate. When it's used for partial seizures, absence, myoclonic, Lennox-Gastaut syndrome, and it's effective also in bipolar disorders. It is potential life-threatening. It causes life-threatening dermatitis in pediatric patients. Again, the half-life of lamotrigine is affected by medication that's inducing the metabolizing enzymes as well as inhibiting the metabolizing enzymes, and it is well tolerated by the elderly people. طيب, the next and the very most famous medication in anti-seizures is the valproic acid or sodium valproate. It is fully ionized at the body pH, and the ionized form is the one actually that's the active form that gives us the action. Its mechanism of action is very broad, and we cannot say that there is only one specific mechanism of action of valproic acid. So it can, some theories of explaining the mechanism of action says that it blocks the sodium channels. It might also block the NAMDA receptor. It also increases the GABA levels by stimulating the glutamic the synthesis of the glutamic decarboxylase, which is responsible for the GABA synthesis. So it increases the GABA synthesis. It also inhibits the transporter, the reuptake, as also it inhibits the degradation of GABA. وفي some theories also talks about that it also targeted calcium channel. So it's very broad. So it is one of the broad anti-seizures that can be used for different types of seizures: absence seizure, mild clonic, as well as tonic clonic seizures. It is available as an oral and IV also, but IV is used for status epilepticus, and it is also used in management of bipolar disorders and migraine. One of the good formulations that we have in the market is that we have a medication that is a combination of the valproic acid and sodium valproate, which is preferred by many patients as it's absorbed very slowly. قلنا برضو إنه valproic acid is one of the enzymes, liver enzymes inhibitors. So we have to be careful about this point. The toxicity is some of the toxicities are because of the dose related, like nausea, vomiting, and GI disturbances. Sedation is uncommon, and then we have reversible side effects. So if you stop the valproic acid, then we have, these side effects will be disappeared. Some of the toxicities or the dangerous toxicities are the hepatotoxicity and the thrombocytopenia. One of the most important, and the one that you had today in today's BBL case, is that valproic acid, when yes, thank you, Majd. When it's used during pregnancy, it causes spina bifida or bifidia in the offspring. So it has to be stopped during pregnancy. Right. The ethosuximide also its effect on the calcium channel. So it reduces the low threshold, which is the T type calcium, yes, calcium channels, and that reduces the repetitive firing in the absence seizures. It is only used in the absence seizures because it has a very narrow spectrum of clinic, and it has a very narrow spectrum of clinical activity. Phenobarbital is the next and the very common and the oldest anti-seizures drugs. It's very common also in children. It is one of the safest, and it's very broad. It can be used in different kind of different type of seizures. Phenobarbital enhancing the inhibitory GABA process. So if you look here at the GABA receptor, it has a couple subtypes like alpha, beta, not subtypes. It has يسموها ايش هم anyhow, so it has alpha, beta, and gamma. Barbiturates, yes, phenobarbital or barbiturates binds at this site. GABA itself binds on the alpha and beta, and also barbiturates bind on the alpha and beta, but it binds to the another sites of the GABA, as well as another sites of the اللي هو other anti-epileptic drugs. So what it happens if that if the phenobarbital or barbiturates bind to the GABA receptors, it reduces the excitatory glutamate transmission at the therapeutic concentration, and allowing the chloride ions to move into the cells. Type. Another also mechanism is that it suppresses the high frequency by acting on the sodium conductance, but that's only at very high concentration. At high concentration, barbiturates also block some calcium currents, but the main mechanism is that it enhances the GABA process by binding to GABA receptor. Benzodiazepines, again, they bind also to GABA A receptor, but benzodiazepines, when they bind on, another site on the GABA receptor, we have different medication of benzodiazepines. Each can be used in different type of seizure. Like due to low time, I will just move through the very important pictures, or sorry, the slides that need explanation. We have then gabapentin and pregabalin. They both are GABA analogs. How they work is that they bind to the alpha 2 gamma subunits of the calcium channel. So they decreases the entry, the calcium entry by binding to these specific channels, and on the presynaptic glutaminergic neurons that leads to decreasing the glutamate release. Sorry, yes, yes. Type. And then vigabatrin. Vigabatrin also it's inhibiting the GABA aminotransferases, which is the enzyme that's responsible about the GABA degradation, and also it inhibits the vesicular GABA transporter. Um, one of the more very important toxicities of the gabapentin is that the visual field loss. I think we do not have time. Do you want to do the interaction? You want to have a break for 10 minutes? I know you have a class after this. Yes, okay. طيب أنا تكلمت مرة كثيرة اليوم. طيب from whatever I mentioned today about the anti-epileptic medication, the mechanism of action, and I put here this illustration يعني from the beginning of the lecture, just to give you a hint about the mechanism of the seizures, also the sorry, the GABAergic and the glutaminergic neurons. So by looking at these two illustrations, what do you think are the common or the major or the general mechanism of action of anti-epileptic drugs? Please be specific. طيب لا تقولوا لي دون block the reuptake. And I put here the illustration to help you remember the name of the proteins or the name of the receptors. So let's be more specific today. Types. The first one who said inhibit reuptake of GABA. How we can inhibit reuptake of GABA? By inhibiting what? Huh? Look at this illustration. Yes, thank you, Dima. By inhibiting GAT1, protein of the that's responsible about the reuptake. طيب whoever said increase GABA, decrease glutamate. How you can increase GABA and decrease glutamate? Blocking GABA, inhibit voltage-gated sodium channels. Yes, thank you. Inhibits excitatory like glutamate, stimulate inhibitory like GABA, block sodium. Okay. Block GABA T enzyme. I think Dima, you can type it. I think I put I give you the permission to write more than one answer if you'd like to write more than one answer. just 5. أنا بغششكم، حطيت لكم الفيجر هنا. You can look at the receptors, you can look at the enzyme, you can look at the proteins of the synaptic vesicles, the reuptake. Inhibit voltage-gated sodium or calcium channels. Okay, thank you. Inhibit AMPA and NAMDA receptors. Thank you. Okay, sorry. Stimulate postsynaptic GABA. Okay. Block NAMDA and AMPA receptors, stimulating GABA A. Why I cannot see? Oh, okay. Stimulating GABA A and GABA B. Yes. Does anyone would like to add her answer, or should I move? One more minute and then I will move. What do you think? Okay, Dima. Look at this and tell me why we inhibit NAMDA and AMPA. Hi, Dima. Tell me why. Yes. NAMDA and AMPA receptors are the two receptors that are the two glutamate receptors. Yani glutamate, if it does not bind to NAMDA or AMPA, then it does not give any effect. Because glutamate binds to either to AMPA and NAMDA, and then AMPA and NAMDA, yes, and then that opens up the channel, and that leads the sodium and chloride to move in, sodium and calcium to move in and excited the postsynaptic neuron. Is it clear, yeah, Lima? Okay, thank you. So the last question, which is talks about the last objective in this lecture, is that from your point of view, after we talked about all the uses and the available treatments that we have as an anti-epileptic drugs, what are the reasons for still we need, or there is still high need to discover new anti-epileptic drugs? Why would someone think about new drug if we have all these medications already available in the market? What are some of the reasons? Yes, thank you. One says that because there is no prophylaxis treatments. Side effects and toxicity. Yes. What else? Do we have anything that cure toxicity? Resistance, teratogenicity. What else do you think? No anti-dose? What do you mean, Sumaya? What's no anti-dose? if you want to treat toxicity, then why do you use this medication? And then we prefer, that's right, we sometimes treat toxicity, but we do that if there is no other options. Like, for example, for cancer, صح? We have to use these medications, otherwise there's a risk versus benefits. But if there's other choices, then why would you give a patient two medications rather than one? So if you give the patient one medication and that causes toxicity, then, and if you have other options, then preferable to switch rather than treat the toxicity with another medication, which might cause drug-drug interaction or which might cause another side effect. Okay, Sumaya. So this can be a reason, but this is not one of the reasons that you will use it to discover new medications. Okay, and one says epilepsy is very damaging to damaging to patients' quality of life. Still, even with our current treatments. طيب, what would make you, يعني, what can you think? What is the thing that because of it you wanna get a new medication? Cost, yes. Safety during pregnancy. We do have anti-epileptics that are safe during pregnancy. What do you think about the frequency of taking these medications? What do you think? So people can do things without worrying about suddenly getting a seizure. Not very practical, says Dima. The frequency of taking. Yes, we have patients who are suffering from a disease that every day they have to take a medication, and then otherwise, if they did not take their medication, it's not like, for example, let's say hypertension. If patient miss one dose, then or 2 or 3 doses, then that does not affect their routine, like daily life. So we need, thank you, we need something with a longer half life, like something that patient can take it once a week, once a month, or once 3 months, or things like that. So we have there are actually some studies that's under development of what we call depot anti-epileptic drugs, which depot medications is like, like you inject a reservoir of this medication into the patient, and then that's slowly released in the body for quite good time, and that what would reduce the frequency. طيب, I guess times is up. Thank you so much, guys, for your participation. I love to see you participating and answering these questions. So we'll see you next time.